just getting ready to start. So I'm going to go ahead and start this morning's session, day 2 of our Texas Business Group on Health Regional Benefits Forum that we titled Back to the Future. And boy, is it ever back to a new normal future that we're looking at. But the uncertainty remains, and the challenges that the benefits managers of different employers and their service providers are facing are as large and looming as any other time. So we're pleased to be able to present this year's regional forum virtually. We're doing it over 2 days, as you know. So if you'll go back to the sessions, Michelle, we've got 2 sessions today. Yesterday's 2 sessions focused on advanced primary care at the epicenter of healthcare's future. It was an excellent presentation. And for all of those who have registered, we do have recordings of both of yesterday's sessions. The second was one on the impact of delayed care due to COVID on employee health and healthcare costs. So both sessions were outstanding. We had a great turnout for it. And again, sessions were recorded. So if you missed yesterday's 2 and want to go back to see, watch them and listen to them, they will be available after the program for you. Today's sessions, we've got 2 more really good ones. One is the quest for total health and well-being, tackling the obvious and the obscure. I'm going to leave it up to you to figure out what the obscure is. I think we all know the obvious. And then the second session of the day, the final one, will be on value-driven pharmacy benefit strategies to curb costs and improve outcomes. And this will, the first part is a 2-part session. I just want to remind all of you. The first part is going to focus on COVID's connection and some really interesting data connected to type 2 diabetes and the related comorbidities, related conditions, obesity, heart disease, hypertension, and so on. Part 2 will focus on managing the total person health and well-being, and that will be 2 additional speakers, which I'll introduce in just before part 2. So it's a tight schedule, and you won't have any break between. However, we will have some sponsor showcases. We're very grateful to our 10 sponsors who support this program. And so in appreciation, we're giving each of our sponsors an opportunity to showcase in a 3-minute showcase before and after the different sessions. We intersperse those between the sessions. So it's a good chance to take a look at what some of these innovative products and services that are available through our sponsors. So stay tuned for that. For the first showcase that I'm going to introduce is Sanofi's showcase. And Bridget Wright works with Pfizer, works with Sanofi, and is going to talk about some of the services and resources that Sanofi has produced and makes available to employers. So with that, if you want to start, Bridget, that would be great. And you're on mute right now. There you go.
Yes, thank you so much, Marianne. I will go ahead and get us started. Yes, so thank you, Texas Business Group on Health, for the opportunity to briefly share with you the Sanofi commitment that supports people living with diabetes. My name is Bridget Wright, and I'm the Regional Account Director supporting the Sanofi General Medicine's portfolio in the great state of Texas. As a registered nurse, like many of you, I share compassion and commitment to addressing the barriers that exist in achieving glycemic control in people living with diabetes. Why are we committed to act differently? With over 463 million adults globally living with diabetes, half of these individuals are not at a recommended targeted A1C goal. Although new therapeutic classes are available, healthcare outcomes have not substantially improved. Barriers such as lack of treatment adherence, therapeutic inertia, and insufficient access to appropriate treatments persist that prevent people from achieving glycemic control. Here at Sanofi, we are a trusted and innovative partner that is at the forefront of diabetes management for nearly a century. Our advances have defined the standard of treatment. We are leaders in real-world evidence with a broad insulin-based portfolio with the power of digital and personal technology, where we are seen as valued partners to educate and support diabetes management. So what's next for Sanofi? We're committed to improving patient outcomes through approaches that align to enhance personalized medicine. Through utilizing data generation to customize treatment approaches, optimizing current connected ecosystems, and employing novel digital platforms to engage external stakeholders. Sanofi is committed to patient affordability. We offer co-pay assistance programs for commercially insured patients. For uninsured patients, we offer a robust savings program that I will highlight momentarily. And through the Sanofi Patient Connection, we offer an assistance program at no cost to low cost for middle income patients. Sanofi also participates in the Medicare Part D Senior Savings Insulin Model, where patients have a more predictable copay for $35 a month for a 30-day supply of insulin. Commercially insured patients are eligible to receive a copay card for our Sanofi insulin brands. The Insulin Value Savings Program guarantees a $99 price for any of the Sanofi insulin brands. View our offerings and learn more about our affordability programs by typing in the web addresses seen below. I thank you for your time and attention, and if you are committed to improving healthcare outcomes, I encourage you to learn more about ways we can partner and address the unmet needs in patients living with diabetes by contacting me directly. I look forward to partnering with you soon. Thank you.
Bridget, thank you so much for this short presentation and the resources and the innovations that Sanofi is doing. It's exciting in the diabetes condition. I think what I'm going to do is introduce Dr. Connard. He's not available yet. He's out of town and he'll be back shortly. So before the second part of the session, oh, there he is. I can introduce you. Hi, Dr. Connard. I was going to put you off for a second, but I don't need to. The first part of, well, first of all, let me introduce Dr. Connard. So he has a long bio that is worthy of studying, but just some highlights. Dr. Connard is a practicing family physician and passionate about transforming healthcare to provide more convenience, increase access, significantly improve quality, and lower cost. And he believes that these goals are not mutually exclusive. In fact, the surest path to lower costs lies in a better model of care that embraces preventive care, yes, we talked about that yesterday, early detection, yes, we talked about in our session about delayed care yesterday, and excellence in management of known conditions and improved behaviors, which we also talked about in yesterday's session on the primary care. Dr. Connard is he's a medical director. He works with a lot of corporations, not just in Dallas-Fort Worth, but over in many other places. Works with employer coalitions around the country. In fact, he serves on the physician council of the National Association of Healthcare Purchasing Coalitions. And he also serves as the medical director for the Dallas-Fort Worth Business Group on Health and is a wonderful advisor that we tap his expertise all the time. His work in patient engagement has led to the development of a new model for chronic care management, which builds knowledge and skills resulting in better health conditions. So, Dr. Connard, I'm going to go ahead and introduce part one, and then we'll move into part two. So part one focuses on, this is interesting, we won't do this yet, we'll come back to that. Part one is interesting in a sense that Sanofi is sponsoring the type 2 diabetes report for Texas, and they produced this report for us using claims data from commercially insured claims data from all over the country that they sift, analyze, and put together in a really user-friendly report. And they've done this probably for the past 10 years for the Texas Business Group on Health. And this year's report is focusing on COVID, how COVID impacts other conditions like diabetes, obesity, hyperlipidemia, high cholesterol, and hypertension in several major cities. And the interesting part is it breaks it down on the cities that we're most interested in, where our coalitions are: Dallas, Fort Worth area, Houston area, and San Antonio, Austin, and several others, but we're going to focus on data particularly from these two. And so we have two presenters today for part one, both from Sanofi, and not both from Sanofi. One is from Fort Analytics, the guy who knows all the data. Starting with Maribel Borisiak, she's an Outcomes Liaison Associate Director. Can we move to her bio? I'm not sure where that is, Michelle. But in the interest of time, I'll just tell you. So she is the Outcomes Liaison Associate Director for the General Medicines Division of Sanofi. And her focus is on diabetes and cardiovascular disease, and she's the medical lead for national and regional accounts. Maribel provides scientific information and clinical insight around products and disease states to payers, PBMs, and large customer groups, including employers. So she's cut her teeth on this kind of work when she spent 16 years at Walgreens, where she had various leadership roles that focused on retail operations and specialty, and as patient care and advocacy senior manager. So she's got all of her information is there, but let me go ahead in the interest of time and introduce Jake Olson. He's the Senior Director of Data Analytics for Fort Analytics, and he's the guy who put together all the data that he will be able to show us on type 2 diabetes and related conditions. So Jake is, the Fort Analytics is an analytics-driven communications company that specializes in the strategic presentation of data for healthcare and other technical industries. Jake has over 20 years experience in the healthcare industry. He works with health plans, insurance plans, providers, pharmaceutical manufacturers, long-term care providers, integrated delivery networks, and helps them identify gaps in care, document best practices, and understand industry trends using real-world data. So Maribel is going to start out to talk about the COVID in particular and its relationship to type 2 diabetes and other conditions, and then followed by Jake. So first slide, or Maribel, however you're going to work it.
Well, thank you so much, Marianne, and Bridget will be kind enough to project for me. Hopefully, we finish this presentation without a glitch with internet access. So she moves forward to the next slide. Great. I just wanted to kind of set the stage today for the conversation we're going to have, the discussion we're having. And today we'll be speaking, unfortunately, about a still very relevant topic, right? And again, to stage that a bit, I heard once a diabetologist talk in a webinar stating that we're really dealing with two pandemics. One is COVID, obviously, and the other pandemic is diabetes, as it's really becoming more and more prevalent globally. Now, my colleague Bridget Wright opened our conversation or discussion noting what a global pandemic problem this is, right? With 463 million adults living with diabetes, that's about 9% prevalence. And if we narrow that scope down and look at the US specifically, it's even more prevalent. Over 1 in 10 of the US adult population, so that's about 34 million, are estimated to have diabetes. But by 2050, we're looking at about 1 in 3 adults with type 2 diabetes. So the presentation today, we'll be looking at diabetes and COVID and how they really impact one another. And as employers, you're very aware of the implications of diabetes to your employees and to your organization. So I do hope that you'll find the information interesting and relevant. If we go on the next slide and we just look at what type of data on what type of people are at high risk for hospitalizations and death, we knew very early on that the chances of getting very sick with COVID-19, it goes up with age. We know that a greater number of older folks are being hospitalized compared to the younger folks, and you can see that on the left side of the slide. Older people are also reported to be at higher risk for mortality, and you can see that on the right, where you see the percentage of deaths increases with increasing age. And although you can see that the overwhelming percentage of deaths are in the Medicare age population, that's the blue shades of the pie, or I guess I should say donut here, 1 in 5 or 20% are in the working age group. Now, this was data as of October 2020. What's concerning is when you look at more recent months, you're really starting to see more deaths and hospitalizations in the 50 to 64 years than in the other age ranges. And if we go on the next slide, in addition to older age, you're seeing chronic comorbidities also increase the risk of severe COVID-19 infection and death. So here you can see the most common underlying comorbidities that you see in COVID-19 patients, and they're listed for you, top 3 being cardiovascular disease, diabetes, and chronic lung disease. But what's interesting in this data is I mentioned the overall prevalence of diabetes in the US is about 1 in 10, about 10.5%, yet the prevalence of diabetes in COVID patients is about 3 times that. And when you just look at hospitalized COVID patients, more than a third, 34 to 38%, have diabetes or uncontrolled hyperglycemia. Now, this is highlighting this relationship between COVID and diabetes that we're going to keep talking about. And if we go on the next slide, obesity is another high-risk factor for complications from COVID-19. There's an increasing trend in COVID-19 hospitalization with increasing body mass index. So this is a study in England where they saw overweight patients, those that had BMI 25 to 30, they're 1.39 times more likely to be hospitalized when you compare them to those that have normal BMI. So that's 18.5 to 25. And that risk of hospitalizations, that keeps increasing as you increase in BMI. In fact, those with a BMI of more than 35 are 3 times more likely to be hospitalized. And the one thing to connect that again to our diabetes, people with diabetes is in the US, 90% of people with diabetes are overweight and over 60% are considered obese. So the next slide, if you actually think of all the slides that we just talked about, we know that older age, having 2 or more comorbidities and obesity are predictors of poor prognosis. And if you think about your typical person with type 2 diabetes, they probably have all of these. So we know that prevalence of diabetes increases with age. In fact, the average age of patients with COVID-19 and diabetes is greater than those with COVID without diabetes. People with diabetes have a greater prevalence of those comorbidities, the cardiovascular disease, hypertension, et cetera. And as I mentioned before, 90% of them are overweight. There's actually one study that showed that COVID patients who had a BMI of more than 35 had a 7-fold greater risk for invasive mechanical ventilation than those that had a normal BMI. So knowing all of this, you can really start to see why people with diabetes are at a greater risk for poor prognosis. And in the next slide, when we, why does diabetes result in worse outcomes when you add a COVID infection? And people with diabetes, and that's the reason behind that is they already have a chronic inflammation at baseline. Well, this inflammation actually contributes to the hyperglycemia that they have, but then hyperglycemia also causes more inflammation. So when you add an acute infection such as COVID on top of this, you're going to see more inflammation, making that hyperglycemia and the diabetes condition worse, ultimately leading to that poor prognosis in these patients. And if we go on the next slide, what we're also learning is that there's this bidirectional relationship between COVID and diabetes. Meaning on one hand, having diabetes can worsen COVID due to all the things we've already talked about, right? Inflammation at baseline, older patients, especially if they have type 2 diabetes, and they have all those other independent risk factors like obesity. But on the flip side, on the other hand, COVID itself, it can also worsen diabetes. And this is because the COVID virus can actually affect or destroy the cells that produce insulin in our body, which can make things really worse for a person with diabetes. So there are reports that COVID may actually worsen hyperglycemia in those diabetic patients, causing more serious complications such as severe diabetic ketoacidosis. And in some cases, there's even reports that COVID may even cause new onset diabetes. In fact, there's a global registry called COVID-Diab that's actually collecting data on new onset COVID-related diabetes. And next, however, knowing that all of this is happening with a diabetic patient, that severity of COVID may be increased, we're also finding out that diabetes itself, it doesn't seem to increase the risk of getting the virus. So put in other words, People with diabetes are no more susceptible to contracting COVID-19 than those without diabetes. But if and when they do get infected, it is a lot worse for them. And you'll see that in the data again and again. In fact, in one study, patients with diabetes or those with uncontrolled hyperglycemia, they're 5 times more likely to die than people without diabetes or uncontrolled hyperglycemia. And in another study of patients who died from COVID, the ones that had diabetes were more likely to have been on a mechanical ventilation or in the ICU versus those without diabetes. Again, highlighting that relationship. And if we go on the next slide, so we know that patients with diabetes do worse with COVID. And we also know that high blood sugar makes inflammation worse and vice versa. So now we're looking at data here and the association between blood sugar control and mortality. And this one is a study in England looking at A1C prior to hospital admission. So COVID-related deaths was significantly higher in those type 2 patients with an A1C of 7.6% or greater versus patients that had an A1C between 6.5 to 7%. And that risk increased with increasing A1C levels. This risk, interestingly, also is increased in people younger than 70 than those age 70 or older in type 2. On the left side here, that's just data that says there's a similar trend for increased deaths with higher A1C levels for type 1 diabetes as well. So the key takeaway here, and what this tells us, is if a person with diabetes does not have a good blood glucose control as reflected by their A1C, even before they set foot in the hospital, and when they get that virus, this lack of control may actually increase their likelihood of dying. So the next slide is going to go over the recommendations for ADA around glycemic control, because again, the crucial message here is achieving adequate glycemic control is important with managing diabetes in the pandemic. A1C is still going to be your gold standard in monitoring glycemic control. Use of self-monitoring blood glucose using test strips and meters, that's going to be helpful with therapy adjustments. Same for CGM or continuous monitoring glucose, as in addition to other things. Patients should really be re-evaluated every 3 to 6 months so that therapy can be adjusted appropriately and patients can reach their A1C goals. And when we see that they have A1Cs that's really higher above their goal, 1.5% or higher above the A1C goal, we want to make sure that they're on the appropriate therapy. And in a lot of these patients, that might be requiring more than one medication in combination. So again, these recommendations in the context of pandemic, where they may be deferral of care, it's just very important to highlight. So, since we know that glycemic control can impact the outcomes of people with diabetes. So now we're going to talk about in the next slide, the expert guidance for people with diabetes during the pandemic, according to ADA and CDC. And this includes lifestyle recommendations, such as maintaining a healthy diet, staying hydrated, continuing to exercise, as well as therapy management from monitoring blood glucose regularly, taking their medications regularly, and avoiding insulin rationing. And I wanted to highlight this because we want to make sure we keep this in mind. Per ADA, 1 in 4 people with diabetes actually ration their supplies. And that includes skipping their injections, insulin injections, that's taking less insulin than they need to, and skipping tests altogether. This also mentions understanding sick day rules, which are those additional steps to follow when your employees are sick, such as testing blood sugar more often, adjusting their dose for insulin accordingly, drinking plenty of fluid to prevent dehydration, and then when to call their healthcare providers. And then this next slide just brings us to planning around the pandemic, and before even our employees get sick, what are some of the things that they need to keep in mind? And per ADA, people with diabetes should really work with their healthcare team to make a sickness plan. And this is making sure that they have a list of their healthcare providers. So that's anywhere from their doctors, pharmacies, insurance providers, knowing when to call that doctor, as we mentioned before, having that adequate supply of both not only their medications, but their testing supplies as well. They recommend having enough insulin for at least 14 days in case patients get sick, they have to quarantine or can't refill. making sure, again, that they have those glucagon and ketone strips in case of the lows and high blood sugars, and having enough stock of simple carbs just to make sure if they're risk for hypoglycemia and they're too ill to eat, that they have that on hand. And really, I want to end here and just summarize what we discussed today. You know, there is that important link between COVID-19 and diabetes that's bidirectional. And not only are people with diabetes, they're at increased risk for a more severe course of infection and mortality, but that COVID itself may make diabetes worse and can even cause new onset diabetes in some instances. But really the key takeaway here is how important it is to have diabetes under control, just because that poor glycemic control can worsen the outcome for patients with COVID-19 when they have diabetes. And so that's the end of my presentation, and I thank you for your time and attention.
Okay, thank you so much, Maribel. We're going to go right into Jake's slides where he talks about the connection with
I can take your information.
Okay.
Just let me know what it's.
So we're getting that set up. Great solid information. I appreciate that. So
Okay.
Jake, whenever you're ready, we'll get
Okay.
your slides up and running. And
great, thank you so much.
yeah.
And
Okay.
yeah, as we pull those slides up, I did want to say thanks to, Maribel, Bridget, Marianne, and the TBGH for letting us come on and have this discussion. As Maribel mentioned, we're going to be speaking a little bit more about the connection between type 2 diabetes and COVID-19, as well as some other conditions. Bridget started with the global view of diabetes, then Maribel went down to the national view. And through this claims look, we're going to talk about how it's affecting Texas and things like that. So next slide. We're going to go through very quickly just where the data come from. We're going to talk about demographics as well, talk about some of those age breaks of the things, how type 2 diabetes patients are breaking out across these markets. We're going to talk about A1C testing and results, especially during this time of COVID, how that's important, how charges are being affected, as well as mortality. Next slide. We're going to talk very quickly using these claims data. So this is from IQVIA, which is a leading supplier of claims data. It's a very robust sample of about 11 million patients nationally with type 2 diabetes. It is also looking at prescription drug activity, which is reflective of about 92% of the retail prescription universe. We do see lab data in here as well. That's been integrated into these claims data, so you can kind of see these patients' data side by side. We're also going to look very quickly at some public data from the Centers for Disease Control and Prevention. Next slide. So one of the first things we start off with is just a quick look at the patients, how they break out by age group. And as Maribel mentioned, there is a connection between age and obviously, COVID-19 outcomes. So this is just a breakdown of those patients. So we're looking at type 2 diabetes patients in the denominator. The Austin patients are most likely to be in that 18 to 64 age group. Less likely to be in the 65 and over. On the other end of the spectrum there is Houston and San Antonio, where those 65 and over percentages are a little bit higher. Just the thing to be aware of as you think about your employees and your patients with type 2 diabetes, that elevated age brings with it a number of other conditions, as well as what Maribel mentioned, heightened risk for COVID-19. Next slide. And as we mentioned, we are looking at claims data. So all these information is through the lens of claims. Patients to be in this data have to have submitted a claim for their condition. So if you look about these percentages, they'll probably be a little bit lower than in real life, only because if a patient doesn't see a physician, we're not going to see them in the data. So consequently, this is still going to be directional. And you can see what we're looking at here is that the percentage of patients with COVID, depression, or obesity tends to be higher. And you can see that gray bar there in Dallas, Fort Worth, and the percentage with obesity is elevated in both Dallas and San Antonio. So things to think about again, in relation to COVID that Maribel just outlined, a lot of these conditions are going to be, impacting those outcomes. And depression, of course, being a key driver in how patients are receiving treatment. And as we know, certainly during the time of COVID, those a lot of mental health concerns did arise, and we see, in those Dallas markets where that's kind of happening a little bit more. Next slide. In addition to tracking the patient's complications as they arise, other conditions that come up as they've had diabetes for longer and longer, and as they've not perhaps managed their blood sugar very well. A1C is another measure of how well they're tracking or how well they're managing the disease. From 2019 to 2020, you see that percent above 9 inched up just a little bit nationally. That could be an effect of COVID-19 as well, because that percentage came down from 2018 to 2019. But in all these Texas markets, among commercial patients, you see, with the exception of San Antonio, the percent in this high uncontrolled range rose a little bit and was highest in Austin, other markets like that. So a thing to consider, as certainly as Maribel drew the line between COVID-19 and A1C for outcomes, it's another percentage to be very aware of. Next slide. So how well are patients monitoring their disease? How well are these patients being screened for the progression of the disease? So the red highlighting here is just talking about the percentage that went down in these different screening tests from 2019 to 20. It's again, another fingerprint, we think, of COVID-19 and deferral of care. Patients are not getting a lot of these screening results as much as they did in 2019. So you can see across the board, eye exams, those percentages went down. Urine microalbumin tests went down. A1C tests went down in a couple of markets. And in Dallas-Fort Worth, across the board, those percentages went down as patients avoided getting those tests done, understandably so in the time of COVID, but at the same time, a thing to be aware of for your employees, especially if they're not getting these tests, the visibility to their progression, to their risk, goes down. Next slide. And here we see, again, through the lens of claims and through the lens of the lab data we're seeing, when you take those patients overall, that's the blue bar. So looking back to the slide a couple of slides ago, the overall percentage of patients with an A1C above 9, is higher in all these Texas markets. But when you take the patients who have type 2 diabetes and COVID, and you look at the percent with above 9 A1C, that percentage goes up as well. So you can see the tie, again, it's through the lens of claims, the percentage of patients with an A1C above 9 is higher among those patients who have a COVID-19 claim as well. Next slide. So in addition to, its effect on A1C levels, you can also see its effect on charges. This is specific to professional charges, those charges by your providers in these different settings. This is specific to the inpatient setting. One thing is between, top to bottom, you can see where charges are highest for in the Houston market, but you go from left to right, you can see also the additive effect of these conditions. So COVID-19 charges are higher for the overall population. The same goes for CKD and for hypoglycemia. Next slide. And obviously, as Maribel mentioned, there is the negative outcome of death. Nationally, we see an additional 23,000 deaths in 2020 among patients who died of diabetes versus the average from 2015 to 2019. And that's not just a national trend. We see it also in Texas on the next slide. And in Texas, that number was close to 2,700 additional people with diabetes who died. And hopefully with this additional awareness and, with obviously some efforts to be, maintaining to prevent the disease, we're going to see this number come down a little bit more. So that's the end of our presentation. Thank you very much for the time.
Oh, okay, thank you very much, Jake. That was really helpful, fast and furious. But I will say that this information is available. We'll make it available too, because so you can look at it in more depth as we get into, as you take this information home and you get to see us, that we share with you. Right now, I already introduced we're going right to the next session. Oh, wait, we're not going to go to the next session yet. First, we're going to have a video from Novo Nordisk in between the two parts. Can we do that, Michelle? Hang on just a second, everyone. Sequencing this, coming right up. There we go. So I want to thank Tom Zabaski, who's our account manager with Novo Nordisk, who has helped us put together this session, and also has been a good partner with us for many years. And he has a short video that he'd like to share with you.
No matter how
Bear with us for just a moment. There you go.
No matter how you look at it, obesity is a serious and chronic disease for your employees and organization. For a long time, we viewed and managed obesity in one way, but maybe it's time to take another look. Your employees with obesity are unique, and weight management shouldn't be limited to just two choices: healthy lifestyle changes or bariatric surgery. Some employees may need another option. Obesity, if left untreated, can have a larger impact on your organization than you think. Employees with obesity are at a higher risk for obesity-related comorbidities.
So, okay.
I do apologize. The video stopped mid flow.
Shall we start it again, or move on to the show, the program?
If you will give me 1 second, we can definitely try it again.
Okay, great. Stay tuned, everyone. There we go.
No matter how you look at it, obesity is a serious and chronic disease for your employees and organization. For a long time, we viewed and managed obesity in one way, but maybe it's time to take another look. Your employees with obesity are unique, and weight management shouldn't be limited to just two choices: healthy lifestyle changes or bariatric surgery. Some employees may need another option. Obesity, if left untreated, can have a larger impact on your organization than you think. Employees with obesity are at a higher risk for obesity-related comorbidities. For example, women with obesity are approximately 4 times more likely to develop knee osteoarthritis, and men are 4.8 times more likely. Similarly for coronary artery disease and type 2 diabetes. While medical costs make up the majority of the financial burden on employers, it's important to consider additional costs as well. Reduced productivity and increased disability and workers' compensation claims take the average annual cost of an employee with obesity from $3,830 to $5,555. Now, you might ask yourself, what kind of impact could this have on my organization? In a 3-year study of employees with obesity who incurred serious injuries, cases of open workers' compensation claims amounted to nearly $500,000. That's a 160% increase in cost from employees without without obesity in the study, and employees with obesity were twice as likely to file a short-term disability claim. Your employees that need weight management have more options beyond lifestyle changes and bariatric surgery. Adding medication to lifestyle changes may help your employees manage their obesity. An employee with a BMI of 40 or more who loses even 5% of their total body weight could create savings for both your employees and organization. Opting in for anti-obesity medication doesn't have to be hard. Your Novo Nordisk account executive can help you navigate the process and gain access to more weight management options for your employees with obesity.
Thank you, Tom, for a great showcase here. We're going to start the next session, and I already introduced Dr. Connor, who's going to show a few slides, but let me just say something about this session overall, including what was presented on the data on COVID's relationship to type 2 diabetes. Obesity and related conditions that have been described and will be described in greater detail are the fastest growing health issues in the United States. And more than 2/3 of Americans are overweight or obese, at higher risk, as we've seen, for diabetes, heart disease, musculoskeletal disorders, and mental illness, including depression. The COVID pandemic has exacerbated every one of these conditions, especially obesity, making weight management as both a health and a business imperative for employers. So we're going to talk about that in this session. And the important thing is to know that tackling obesity is the front door to total health and well-being of your employees, which is what this whole session is about, total health and well-being. With that, I've introduced Dr. Connor, and then he is going to moderate this session, but he's going to set the stage for us, and then I will introduce our two speakers, Jason Lurk and Isabel Allencar. I think that's the sequence that we have.
All right. Well, thank you very much, Marianne. I
Yeah.
hope you're able to hear me. So, it's interesting as a family doctor, I sit in front of patients all day long and talk about the personal determinants of health. And there are 5 of them that we're going to talk about today. First of all is lifestyle. You can go ahead and please advance the slides. And the lifestyle choices. Then preventive services. Do they get cancer screening and things? Know your numbers and get them to goal. If a person has chronic illnesses such as obesity, diabetes, hypertension, high cholesterol, asthma, COPD, those kind of things, their chronic illness care choices and making sure to close the gaps. And of course, their serious illness. If they have something that maybe Parkinson's or myasthenia gravis, multiple sclerosis, sickle cell, those things, making sure that those diseases are cared for. And that's called primary care. Those are the personal determinants of health. On the other end of the spectrum are the social determinants of health. And we've all heard about these and how COVID has really brought to fore the inequities that the social determinants have had on our populations, particularly those of color and those that are less affluent. So the social determinants are education and access to quality. Go ahead and advance the slide, thanks. Healthcare and quality, neighborhood and the built environment, social and community context, and economic stability. Now, there's been a lot of pressure on corporations to take responsibility for this and to somehow address this. But for me, that feels really overwhelming for a corporation to think about in that regard, just as the personal determinants of health feel a little inappropriate, perhaps, for them to delve into, because that's about the individual. So what are the corporate determinants of health? And this is not a term that's in the marketplace, but if you'd advance to the next slide, it's one that I'd like us at the DFW Business Group to really think about together. And that is, how does our corporation determine through the environment that people are working in, the culture of our corporation, the access that we give people, and the affordability, particularly, of the health benefit plan, is a training and development, which makes a huge difference in all aspects of their life, and of course the salary and other benefits. So let's look at a couple examples of this. Go ahead and advance if you would. Thank you. So the environment, the safety, the space, the air quality, the ergometrics, access to healthy food, to not being stuck in a chair, to having access to healthy water, maybe tea without sugar and other things in it, and so forth. The culture, is it supportive or hostile? Is it tolerant or discriminatory? How conscious is it? Is it relational or very transactional? The healthcare access. What is the benefit design? I did an analysis of a company recently where when we looked at the affordability, 72% of their employees couldn't use their healthcare insurance because it was too expensive. The truth is we design the healthcare benefits for the C-suite. We don't design it for the average worker in general. Average worker doesn't have any input into what the benefits are. So we need to really think about that. What are the copays and deductibles, the pharmacy benefits, and what are the other programs like, say, Wonder, or some companies use Livongo and Omada to benefit or improve health. And finally, the training development goes without saying, and go ahead and hit the forward button. And the salary and benefits makes a huge difference. And you know, we have in many corporations, we have the working group that the percentage of people in a corporation that make less than $45,000 to $50,000 a year in many corporations is 60 to 70%. So they're really the people who live right at the poverty line that are employed. So what are some examples of what we've got now? I just wanted to really try to drive this home. An unsupported group is like a standard high deductible health plan with an HSA, $2,500 to $500. The average couple or individual doesn't have $400 to pay, let alone $2,500. A standard open network, you know, here's our doctors, good luck. And that means that 50% of all the doctors in the network are in the bottom 50 percentile. Colonoscopy, if they go in for a colon screening and they happen to find a polyp, they're now going to get hit with a $2,800, $3,200 bill and the usual PBM formulary costs. So, and you know, having an open formulary is a license for PBMs to steal. 2 years ago, there were 83 new drugs. 3 of them had benefit. The other 80 were scams and games that were companies that bought up generic drugs and were now charging people usurious rates. So having an open formulary is a bad idea when it comes to particularly high deductible health plans because you shellac the employees, and closing that down is a very good idea. A supported example of a health plan would be maybe an HRA, where you can have a lot more flexibility in what you're able to offer people. Again, HSAs are great for the C-suite, but not the average worker in general. No cost for high value primary and preventive care, which again, with the HSA, you can't do often, or you have to be very thoughtful about how you do it. But with the HRA Flex or PPO options, you can do. Colonoscopies are covered, regardless of whether it's for polyps or not. Again, can't do that with HSAs or it's difficult, but with the other plans you could. And I mean, no one's going to say, hey, I think I'll go have a colonoscopy today for fun, right? That's silly. But to have people go get a screening colonoscopy and get hit with a $3,000 bill is also is not acceptable. And frankly, a lot of people don't get cancer screening because of that fear. All chronic medications, particularly generics, if you don't want to do everything, just do generics. But generics, brands without generic alternatives, having that be free to employees is something that we do in most every plan that I have the opportunity to work with. It's not that expensive relative to one ER visit because somebody didn't get their medicines. And the travesty of insulin that we heard earlier, people die when they don't use their insulin, but they can't afford to go buy it. You know, do I pay my rent? Do I buy food for my kids this month, or do I go buy insulin? That's a tough challenge. And having the chronic medications be covered is one way to get around that. Getting rid of the low value drugs. It's amazing to me how many health benefit plans, the number 1, 2, and 3 drugs from a cost standpoint that aren't specialty are low value drugs that shouldn't even be on the formulary. Duexis, a great example. It just drives me nuts that you've got people who are paying thousands of dollars for a drug that you could buy literally for less than $1 a day over the counter. And then from the work that I do, having pathways of care is very, very important, and centers of excellence or using vendors that will help direct people to high quality providers is very important. Go ahead to the next slide, please. Oh, and of course, support navigating people through the system. Most people have never had the problem they're trying to navigate before. They don't know where to go. They don't know what to do. And it's amazing to me how many companies have amazing benefits and they have people in need, but that last mile between the two is not, there's no bridge to having them actually use them effectively. Go ahead to the next slide. So to finish up, I just wanted to create a 2x2 picture that maybe we can start to develop some thoughts off of. Oh, no, go back. Please go back one. There you go. So if you think about having a proactive mindset versus a reactive mindset as a corporation, next slide now, thank you. And then having these corporate determinants in unsupported plan versus supported plan, when you put those together, you find there are four kind of situations people find themselves in. Go ahead to the next, just hit it one time. Good, stop there. Disengaged people are people who, that it's a reactive plan and there's no support. They're the lost souls. They wander through the healthcare system, spending money inappropriately, getting inappropriate services and treatments. And unfortunately, that's probably 85% of all health benefit plans. Hit it one time, please. Then you have the disengaged who are supported. So they have a fighting chance. They're going to have someone reaching out, guiding them to an appropriate area level of care. And then, but they aren't engaged personally. The next one, hit it one time, is the people who are engaged and unsupported. These people are distracted. They're trying to figure out, how do I use the system? Where do I go? How do I find the best doctor? What do I do? What do I do? And often they take a lot of time when they're at work to do these, and they're not present and working well for you. And finally, we have the people who are engaged and supported. They're in the flow. They're using your benefits intelligently. They're much less expensive because they're getting the right care at the right time, at the right place, by the right provider at the right price. So I would really challenge us all to think about what's happened with COVID and figure out how we get our employees to that right upper quadrant. Go to the next slide. I think that's the last one. And then let's go straight into our Q&A. And I don't know whether we're going to leave the slides on. I'd ask those of us in the Q&A to go ahead and turn your cameras on. And I'm going to hand it off back to you. I think.
Okay. Yes, let me do a very brief introduction for our next for part of the discussion for this managing total person health and well-being. Jason Lurk is going to be one of our speakers. He is the Medical Accounts Associate Director at Novo Nordisk, and in this role, he supports large employer groups, employer coalitions, including Dallas-Fort Worth Business Group, Texas Business Group, San Antonio, and Houston, and benefits and consultants to ensure comprehensive understanding of diabetes and obesity clinical information as it relates to the total health, well-being, and productivity of employees and their dependents. And then we're pleased to also have Isabel Alencar, who is the Vice President of Clinical Services with Catapult Health. Isabel leads Catapult Health's team of nurse practitioners. She's a board-certified acute care nurse practitioner with extensive experience in the treatment of cardiovascular disease and diabetes in adults. She's passionate about the preventive medicine and patient education, believes in empowering individuals to live healthier lives, and she joined Catapult in 2020 and serves as a member of their Catapult Health Medical Advisory Board. So both Jason and Isabel have some interesting discussion that we're going to have. And Dr. Connor, thank you for being moderator for this session. Really appreciate it. I encourage everyone to ask questions or put in the chat box some comments, and we'll address those during this discussion.
All right, very good. So, Marianne, are we going to have questions that appear, or how do you want me to? How do you want to drive this conversation?
Well, I think if there are questions, they'll appear in the Q&A or chat box, and you'll be able to see those. But basically, I know that Jason and Isabel have some interesting information to share, and I think you might have slides as well. Is that right, Jason? Yeah. Okay.
That's great, Marianne. And maybe I'll go through our slides and see if I don't see anything in the Q&A yet. Just back one slide real quick, sorry. So thanks again, Marianne, for the opportunity to speak. And as you said, Texas Business Group on Health, Dallas-Fort Worth Business Group on Health. I just want to re-mention what you had in the description, because I think it's powerful that obesity is the fastest growing U.S. Health issue in the United States. And really today, I want you guys to be able to, gain a better understanding and appreciation for tackling obesity and help the total health and well-being of your employees. So let me move this pop-up. All right, now you can move on to the next slide. Thank you. And this is a great snapshot of looking at 71% of the United States adults have obesity or overweight. And if you see there in the middle, about a third of the population is overweight with the body mass index listed. But what I want you to focus on is the right side of the slide, that 1 in 6 or 17.5%, if you add those two, have either class 2 or class 3 obesity. Those generally are your high cost claimants, have multiple chronic comorbid conditions, and really may impact your health plan spend from an employer perspective. So next slide. Reiterating or looking in bar chart, I really think this is a unique way to look at it, that obesity is more prevalent than any other major chronic chronic disease, and it's just as prevalent as you see there hypertension, with about 108 million folks having obesity, same as hypertension. And then you kind of jump down, see the prevalence of chronic kidney disease, type 2 diabetes, osteoarthritis, asthma, coronary artery disease, and cancer. So trying to be able to focus on those 110 million folks who have obesity and better provide treatment options, and looking again at that overall health and well-being of an individual. Let's go on to the next slide and think about some of the chronic comorbid conditions associated with obesity. And the reason I want to show this is these are generally what we do a good job as a medical community treating. We're treating the chronic comorbid conditions, but can we do a better job focusing on obesity, which most likely can be causing or worsening these chronic conditions? So to highlight the mental, mechanical, and metabolic, they're broken out on the left side of the slide. Really, depression and anxiety are common in the obese population. We'll dive deeper into that. You see there's some of the mechanical issues of asthma exacerbations worsening in the obese population versus normal weight, cardiovascular disease, and then there are actually 13 cancers that are at increased prevalence and incidence. And I do want to just check in. It says that it's still on my first slide. Is anyone else seeing that, or it have the slides advanced?
They're advancing.
Okay. I just saw it pop up down at the bottom of the chat. So that sounds great. So with my next slide, let's take a deeper dive on the kind of mental component and look specifically at depression. So you can advance the slide. So, listed here, I know it's a very wordy slide. I'll kind of walk you through it, but depression and obesity are interconnected. This definitely is a hot topic in the employer space today about the mental health and well-being, as well as kind of that physical. That's why we had the great title of tackling the obvious and the obscure. If you look, does obesity cause depression, or does depression cause obesity? It may not be as simple as an answer that's listed there, but they are considered interconnected and really reinforcing each other through shared biological mechanisms. Down at the bottom, obesity is more common in people with depression than those without. Obesity rises in prevalence as depression symptoms severity increases. And on the bottom right, obesity and depression both increase the risk of complications of coronary heart disease, type 2 diabetes, and other infections. In the middle, weight loss medications, weight loss measures are and have been associated, it's been documented with significant improvements in depression in individuals who can have adequate weight loss. So next slide. We had great presentations previously around COVID-19, type 2 diabetes. There was a little mention of obesity. I just have this one slide on COVID-19 and severe illnesses from COVID-19, really looking at the obese population. This data is looking at what would be a commercial population, all individuals less than 65 years old. If you see anyone with a body mass index of 30 to 35, which would be a class 1 obesity, they were associated with about an 18% higher risk of hospitalization compared to a healthy weight individual, and almost a 59% higher risk of hospitalization for body mass indexes over 45. And there has been data around ICU admissions and the obese population having a higher increased risk of ICU admissions. So next slide. And this slide, I think, really is important to show in the employer space. And the title of it is People with Obesity Believe They Should Manage Their Weight Loss Alone. And data shows on the far right that individuals have on average, 7 serious attempts at weight loss before they even approach their healthcare provider. They generally think that it's their responsibility, don't really understand maybe if it's a chronic disease or which category an individual may fall into, normal weight, obesity, or overweight. So I think the reason I talk about this is going into my next slide, talks about how maybe an employer can help implement, as Dr. Conard said, that positive, proactive approach. And this is just a small list of ways, but really there can be small changes that can create this comprehensive, multifaceted approach to tackle employee obesity. Not let them feel alone, not let them have 7 on average attempts at weight loss before talking to even a provider about it. So here are things on the left side: creating a healthy workplace. I know a lot of employers have gym memberships, considering maybe an on-site or near-site clinic, increasing that access to care, providing health coaching, nutrition classes, healthy food choices. And then in the middle, opportunities for healthcare provisions, whether it's looking into utilizing centers of excellence around weight management, understanding anti-obesity medications coverage from your prescription benefit, from your health plan, considering bariatric surgery coverage as well. And then identify some of those barriers and remove those barriers, maybe around workplace stress, flexible working hours that would enable more exercise, limited options for physically active commuting. And so with that, I think let's go into the next slide and talk about how then obesity care can be fragmented at the healthcare level. And hopefully employers can help do some sort of integration, is what I like to say, across these benefits subsets. So if you think here, really 3 benefit offerings around chronic weight management, the first one being wellness, lifestyle, behavior modification. The second one being medications or anti-obesity medications, your pharmacy benefit. The third being your medical benefit. And those are really 3 treatment options that shouldn't be used or seen in a silo approach. They're really used in conjunction. The weight loss journey, as you can see, lifestyle modifications may achieve about a 3 to 5% weight loss. Someone then may plateau with lifestyle behavior changes alone. And as they plateau, the body starts making compensatory changes where they try to gain the weight back. That's generally where medications can help block some of those, help aid in additional weight loss. You see here now medications, you can get anywhere from 5 to 16, 17% on average weight loss. And then the medical benefit is generally reserved for body mass indexes over 40 with surgical procedures, but the efficacy anywhere from 16 to higher than 30%. So with that, that is my last slide, and I really appreciate the opportunity to talk about, again, this total health, looking at obesity, looking at the mental component around depression and how those are connected, as well as just a quick slide on COVID-19. And what we closed up here with is really empowering employers to take a proactive approach, help their employees, not let them feel alone, look at the benefit offerings and try to integrate benefits so there's congruency across the 3. With that, thanks for the time, and I'll turn it over to the next presentation.
Thanks so much. I am Isabel Alencar. I'm an acute care nurse practitioner, and I'll be talking about depression in the American workplace as well as the Texan workplace. And thank you very much to TBGH for inviting Catapult Health to be a part of today's session. Next slide, please. So our presentation today is based on the analysis of test results of more than 425,000 Catapult patients over the last 4 years. These patients underwent tests that include physical measurements like blood pressure and weight, health history assessments, and depression screenings. As you can see from the slide, The study population is very similar to Americans as a whole. I'll give you a minute to, I know there's a lot of numbers on this screen. Next slide, please. So the depression screening tool we use is highly validated and widely used, known as the PHQ-9 assessment. And the assessment asks patients if they've experienced symptoms of depression in the previous 2 weeks. The first section of the slide shows the number of patients from the study population who did indicate they had experienced symptoms of depression sometime in the previous 2 weeks and what level of severity they were measured at having. It's important to note that unlike chronic diseases that are usually lifelong and persistent, most depression is episodic. For the patients in the lower half of the slide there, these were those that indicated the possibility of self-harm on the PHQ-9. And so Catapult Health nurse practitioners will verbally administer the Columbia Suicide Severity Rating Scale assessment to patients that do indicate some level of potential self-harm. Of course, those patients do receive additional care and follow-up from our team when that does happen. Next slide, please. So what is depression? It's a term that's often misused to describe just feeling down, being blue, having a bad day, being stressed or anxious. And although all of these things are symptoms of depression, to truly have a clinical depression, these symptoms in any combination need to be persistent for 2 or more weeks, and more notably have to be interfering with the everyday functioning of life for it to be a true diagnosis of depression. Next slide, please. Clinical depression is actually more prevalent than most people realize. Here are some quick facts about it. 4.7% of American adults experience regular feelings of depression. Over the past year, more than 7% of American adults have had at least one depressive episode. Over our lifetimes, 1 out of 6 of us will have depression at some point. Women will have as many as 25% of women will become clinically depressed in their lifetime, and half as many men will develop clinical depression. 11% of emergency room visits are attributed to depression, and it is the leading cause of disability in those ages 15 to 44. And as has previously been discussed in this session, it is a comorbid condition for chronic illness such as diabetes, heart disease, and cancers. Next slide, please. Thank you. So when we break it down by age, our data confirms what many have speculated. Depression is more common among younger people in the workplace compared to their older coworkers. And if you look specifically at those in their early 20s, 20, 21 or so, you'll see that more than 10% of them are actually depressed. You can see as we age, the incidence of depression of those in the workforce does decrease. We do, however, see an increase in depression in those in their 70s and 80s in the post-retirement years, but that's a whole other topic of discussion. It's tempting to speculate why are young adults more likely to be depressed than their older coworkers. And there's many contributing factors like entering the workforce for the first time, maybe living on their own for the first time, having to manage finances, starting families, and nowadays social media definitely plays a part in that. Next slide, please. We also found a strong correlation between one's biological sex and depression, with females having a rate of depression nearly 1/3 higher than those that identify as male. And the small sample size of those that don't identify as either male or female have even higher rates of depression. And we won't look into suicidal ideation findings today, but I will mention that the percentage follows the same pattern with suicidal ideation as the numbers you see here, but it is more pronounced in those that don't identify as either male or female. Next slide. So we also look at race and ethnicity, and we use the same breakdowns for that as the US Census. And we ask each patient what race they associate with. Race is being a mix of physical, behavioral, social, and other qualities that define who we are. And we also ask if they do consider themselves Hispanic or Latino or non-Hispanic or Latino based on their language and culture. So the left side of the screen shows the percentage by race who did indicate depression, while the ones on the right do show those that identified as Hispanic or Latino or not. And we should note that those that are Hispanic or Latino have a depression rate that's almost 50% higher than those that do not. Next slide. We also found a strong correlation between depression and health-related behaviors, more specifically smoking, alcohol consumption, and physical inactivity. People who smoke are twice as likely to have depression compared to those who don't. And the higher rates are also similar for those that abuse alcohol, either through binge drinking or overconsumption in general, and for those that are physically inactive. I will emphasize that although we know the pattern exists, we can't say if the depression is leading the behaviors or if the behaviors are contributing to the depression. It's one of those medical, which came first, the chicken or the egg. And also we have to consider if personal factors that affect depression also affect their behaviors. We do know that alcohol abuse does complicate depression, and that those that are physically active do report feelings of improved symptoms and less depression. Next slide. So you can see here, as we've discussed throughout the session, those with chronic diseases such as diabetes, high blood pressure, heart disease, do experience depression as a comorbidity. Half of the nearly 1 million patients we've seen over the years had at least one chronic disease. And not surprisingly, the data shows that the two most debilitating conditions, COPD and heart failure, patients that do experience these chronic diseases do have higher rates of depression. Almost 8% of the patients that we saw who had COPD also had depression at the time of their checkup. And it's likely that many of these patients have previously experienced depression and will likely experience it again. Typically, when there's disease exacerbation, where more frequent medical care may be required or even hospitalization. And also, there were 3% of patients that had no chronic conditions at the time of their consult who did still report depression. Next slide, please. So the dark blue bar in this chart represents the 2.5% of patients who were normal weight with a BMI of 18.5 to 24.9. On the other hand, the dark red bar on the far right represents the 5.5% of patients who were in obesity class 3 that also had depression, and that's those with a BMI greater than or equal to 40. The group with the third highest rate of depression included those that were underweight, the light blue bar on the far left, and those with a BMI of less than 18.5. So as a point of reference, 22.5% of our patients here at Catapult were in the normal weight range, 1% were underweight, and 46% of them were obese. And then emergency care relative to depression. So about 3 out of every 1,000 patients we see have a health condition serious enough that merits emergency care. These patients are referred either to an urgent care center, an emergency room, or to their primary care provider if they're able to be seen on the same day of their consult with a nurse practitioner. Our team then follows up with those individuals later that same night or the next day to be sure that they went on to the next level of care, as well as answer any lingering questions that they may have. Among symptoms that do produce these emergency referrals are extremely elevated blood pressure, extremely elevated blood glucose. If the patient is having active symptoms of a heart attack, a stroke, have had a seizure that lasted more than 2 minutes on the day of their consult. We also make emergency referrals for those with active advanced suicidal and or homicidal ideations. It's among these patients that we see the highest need for emergency care, and they are 29 times more likely to need emergency care if they're depressed. Next slide. So the next 4 slides focus on the 116,000 patients who live in Texas that we've seen over the years. So you can see the numbers in the gray box relative to the larger study population. They're pretty similar. Main differences are they tended to be a little younger in Texas, a little more likely to be male, and we had twice as many individuals of Asian descent and were much more likely to be Hispanic or Latino. Next slide. Again, we're comparing the original numbers with the Texas numbers in the boxes within the bars. You can see overall the trend for Texas is similar by age group, with the youngest patients again experiencing the highest rates of depression. Next slide. And again, similar trend with depression relative to biological sex. The group for other was actually only 24 out of the 116,000 in the study. So significantly higher rates when you compare side by side. Next slide. And again, similar to the rest of the study in the country as a whole, we follow the same patterns here in Texas. For depression, just noting that African Americans in Texas have a higher rate relative to the overall, and surprisingly, Hispanics or Latino, a slightly lower rate of depression when compared to the greater population. Next slide. So the next 4 slides are tips for employers and what you can do to promote the psychological health of your employees. Communicating frequently about health, both physical and psychological, is important. We have to remove the stigma that exists around psychological health and make it a normal topic, just like we do conditions like diabetes and obesity and such. Let your employees know that both their physical and psychological health are important. I would be remiss if I didn't mention COVID in all of this. The effects of COVID are going to be with us for a very long time, both physically and psychologically. And there is a new normal that we need to look at, and we already are. So we need to be mindful of the physical things that will change with those that have experienced COVID, as well as the psychological impacts of having had COVID or loved ones. So next slide, please. Next one. Be sure your employees and their families know where they can go for psychological health. Here in Texas, especially in rural and underserved communities, sometimes the primary care provider is the only point of contact for both physical and mental health. So being sure employees know what resources are available, what's in network, employee assistance programs, local health, local mental health centers and such. Next slide. And then just knowing, what to look for in the workplace and know the signs and symptoms of depression or possible suicidal ideation. Knowing, managers know your employees well to know if something seems off about them, and encourage them to get help if necessary, in hopes that you may prevent a tragic outcome. That's it. Thank you so much for your time today. Appreciate it.
That's great. Well, thank you very much, Isabel and Jason. This is very interesting information, very helpful. And I will say that the depression and the mental health is a key part of total health and well-being, and you stated it very well, Isabel. Thank you for all your data on that. And Jason, of course, on the obesity side, and everything attendant with that is so helpful. And I want to thank Maribel and also Jake for their introduction on the data, that really useful data and interesting on COVID's relationship to type 2 diabetes and the other comorbidities. So thank you for doing this. We're going to move right along in the interest of time. First of all, I want to thank Behringer Ingelheim for sponsoring this showcase, sponsoring the program, one of our sponsors. They do not have slides or videos, but I do want to thank Marcus Laughlin, who has been a longtime partner with us with the Texas Business Group on Health in Dallas-Fort Worth and Business Group on Health, and has sponsored many of our programs. So I really appreciate your support, Marcus, and hope that we have a continued long-term relationship. The next part is I have a very brief Catapult Health, as well as with Catapult Health. I want to thank you for supporting this program, as well as Novo Nordisk that you just saw the previous showcase. And we've got a short video from Catapult.
Hi, I'm Candace, and welcome to Catapult Health, America's fastest growing preventive care virtual checkup provider. We work with over 400 employers in all 50 states, and our virtual checkup is already a covered benefit for millions of people. A Catapult Health virtual checkup is a win-win healthcare option for companies and employees alike. It saves time, money, and hassle for everyone. We made the virtual checkup fast, simple, and convenient. It can be completed at your work sites, completed virtually from home, or any other location for that matter. The virtual checkup truly is preventive care anywhere. Catapult can easily serve any size company without sacrificing quality or speed. Wishing everyone would go to their PCP every year? Well, that's just wishful thinking. A virtual checkup catches problems before they become problems. We deliver evidence-based outcomes. Every checkup includes a review of personal and family medical history, collection of a blood sample, an import of filled prescriptions, even a digital blood pressure monitor employees can keep. After their lab work is complete, employees participate in a virtual video consultation with one of our certified nurse practitioners. Our NPs walk your employees through their detailed health report, screen them for depression, help them set up a personalized action plan, then refer them into the terrific health improvement programs you already offer. Completely private and done before you know it. We know your employees work hard, and their preventive care should work hard for them. And for those of you running the numbers, a virtual checkup is about half the cost of a PCP office visit with labs. And since Catapult is a medical provider, we simply file a preventive care claim for checkups delivered. The bottom line, Catapult Health delivers evidence-based outcomes that lead to better health for your team and big savings for your company. Oh, and did I mention we have a Net Promoter Score of 81? Employees are loving the virtual checkup that happens on their schedule. So, join a community of millions who already have access to Catapult's virtual checkup. To learn more, visit catapulthealth.com. You're already well on your way to providing a smarter, more innovative approach to preventive care.
Great, thank you very much. In fact, her smile was so big, I couldn't help having the biggest smile on my face as well. It was infectious. So thank you all for this session, and we will take about a 3-minute break, and then we'll be right back for our final session of this year's Regional Benefits Forum. Thank you.